Dr. Raghav is there? Yeah, please come. Raghav, Preetam will be talking on tag team approach in Aphakic, bullous keratopathy and vitreous hemorrhage. Joining hands for glory.
In the following video, we would like to describe our approach to a complex case of aphakic bullous keratopathy and vitreous hemorrhage and describe the advantages of doing a vitreocorneal procedure. A 65-year-old lady from Gadwal presented with complaints of pain, redness and watering in the left eye for a month. She had undergone cataract surgery elsewhere 2 months ago, followed by IOL explantation which was done a month ago elsewhere. She is a known diabetic and hypertensive. Her vision on presentation was counting fingers close to face and IOP was digitally hard. On clinical examination, lid edema, BCL, circumcorneal congestion and total corneal edema was noted. Subtle posterior corneal cellularity was noted with pigment deposition on the endothelium. A retrocorneal membrane was noted superiorly, along with AC cells and flare. However, details were very hazy and pupil was mid-dilated, updrawn with superior peripheral anterior synechiae from 11 to 1 o'clock. Aphakia was also noted. A diagnosis of toxic anterior segment syndrome was made and patient was started on the following medication. Patient reviewed 2 weeks later with the vision stable and Goldmann applanation tonometry readings were 22 mm of mercury. Congestion reduced, cornea looked less steamy and AC was relatively quiet. However, the edema was persistent, steroids were continued and B-scan was repeated. B-scan was suggestive of multiple hyperintense echoes which are close to retina, suggestive of vitreous hemorrhage. The conundrum here is what to do next. Whether we will do a penetrating keratoplasty or an endothelial keratoplasty, what would be the choice of IOL, and whether it would be a single or a staged approach. Pointers which helped us in decision making. Presence of faint posterior stromal scarring and superior 4 clockhours of synechiae meant PK would be an overkill. In view of borderline IOP, irregular mid-dilated pupil, ACIOL or iris claw would not be a good option. There was no PC support and it was aphakic status and sulcus fixation could not be possible. In view of vitreous prolapse and few vitreous echoes in the posterior segment, we decided to go for pars plana vitrectomy with SFIOL and DSEC. Conjunctival peritomy done and 2 scleral ports made using 45 degrees angled MVR blade at 3 and 9 o'clock position. 3 self-sealing 25 gauge PPV ports made and vitrectomy performed. Posterior approach helps in avoiding undue traction and retinal breaks. Core vitrectomy completed after PVD induction. However, during the same, abnormal vitreous adhesions noted superiorly in the periphery and vitreous hemorrhage noted inferiorly. They were both cleared, followed by base shaving of the vitreous base. This approach allows for a complete retinal examination to be performed, following which corneal diameter is measured using calipers, epithelial debridement done, 5 mm clear corneal incision made superiorly and 2 side ports were made. After the entry under the posterior infusion pressure, Auroview 3-piece lens of power adjusted to the dissect lenticule to plus 23 diopters is injected into the AC. Using the handshake technique, the haptics are carefully maneuvered and brought out from the scleral pockets previously made and they are tucked inside the scleral pocket. Once both the haptics are tucked in, a single suture is taken on either side. Following which, Desmet scoring and stripping is done under posterior infusion on. This technique helps in maintaining a stable AC for maneuvering. Superior RCM and dense adhesions can also be peeled off because of the posterior infusion which is maintaining the AC very stable. Once the Desmet membrane is removed in toto from the superior section, an inferior PI is made and the superior peripheral anterior synechiae is released and bleeding is continuously washed away with the posterior infusion. A sheath glide is placed and the lenticule is carefully maneuvered into the anterior chamber. Mind you that the posterior infusion is off during this step. A single monofilament nylon suture is taken at the superior section and then a small air bubble is placed below the lenticule and the posterior infusion is turned on again. This approach helps in safely handling the lenticule and prevent any inadvertent lenticule loss. The lenticule is carefully maneuvered into position. Additional sutures are taken at the superior section and then an air bubble is placed directly into the AC. The air bubble management becomes very easy because the posterior infusion is on doesn't allow the air bubble to migrate posteriorly. Once a complete airfill is achieved, a cross suture is taken along the port and the port is released and the suture tied tightly. Additional air is supplemented into the anterior chamber. The conjunctival peritomy are closed using 80 vicryl sutures. An additional suture is placed through the side port and subconjunctival DEXA injection given. Post-operatively by day 4, vision improved to CF 3 meters and IOP was stable. Lenticle was well attached but corneal edema was persistent. The same can be noted on the anterior segment OCT. By end of 5 weeks, vision improved to CF 5 meters, IOP was stable. Cornea was compact and relatively clear. Centrally there was faint scarring but patient was asymptomatic. To summarize the most valuable points, number 1 is predictability. A complete vitreoretinal examination is possible to prognosticate the case. 2. A judicious vitrectomy can be performed to avoid inadvertent traction or retinal breaks. 3. Air bubble management becomes more predictable as the posterior infusion makes sure that the air bubble stays in the anterior chamber. 2 is damage control. Minimal tissue handling of the intraocular structures is possible. Lenticle handling is much better and posterior migration of lenticle can be avoided. 3. We can have a more stable and well-centered IOL with this technique. 3 is better outcomes. We have evidences from the literature as well in the past where the outcomes have been better in a combined approach with SFIOL and DSEC. In the following video, we would like
Thank you, Raghav, very nice. Only thing is, I would have made the pupil little smaller. The pupil is little bigger for a DSEC because the problem is in glued IOL or SFIOL, there is a potential space between the IOL and the iris. And if the pupil is not come down, that if you don't do a pupilloplasty like an SFT or something like that, then what happens is there's a possibility of the graft getting dislocated into the vitreous, which has happened to me, and something which I think you have been lucky in this case. Anything like, yeah.
How long is the
So follow-up, now it's almost 6 months follow-up. Patient has vision of around CF 6 meters, possibly because of the vitrectomy which was done and the scarring which has been there. But the corneal scarring, the faint posterior corneal scarring. But the scarring is also remodeling with time. So I didn't put the new pictures. So the scarring as well is less dense as compared to immediate post-operative or 1 month.
The scarring will improve, no, usually. Yeah, when you do a DSEC.
vision should have been much
Better.
Yes, but unfortunately the patient is not.
Pinhole
Pinhole lesion is also the same.
Sutures,
Best correct.
astigmatism is there.
So the sutures I removed after 1 month, so there are no sutures now, but still
Because
not
I think, because apart from the bullous keratopathy, if you notice very carefully that video, that picture, there is also some epithelial downgrowth which is coming from top. So that is also accounting for that, I think.
probably.
Yeah.
And the reason why I didn't do a pupilloplasty, I had 2 reasons. One, because of I was worried about the bleeding which would happen again when I was trying to do that. Second thing is the pigment release which happens when I do a pupilloplasty, which again would hamper the efficiency of the graft which I am using. So that those are the 2 reasons.
Such a large pupil, the graft can get dislocated. The graft goes into the vitreous, it's a real problematic.
So that's why I wanted, that was the emphasis of my video, saying that when you have a posterior infusion on continuously,
Yeah.
you just tuck in the lenticle inside and put a small air bubble behind it and keep the posterior infusion on. There is a less chance that it migrates down.
As for the sake of knowing how long is the surgery?
Around 1 hour 20 minutes. Again, the surgery had to be performed by 2, so.
Also, just one last thing. Why did you prefer an air bubble over C3F8 in this case?
So in all our DSECs, we regularly don't try to use C3F8 or SF6. It's the air bubble which is more stable. The advantage is the chance of pupillary block or high pressures is much lower with the air bubble. So this is our primary approach. In case we encounter a detachment in these cases, then when we do the secondary rebubbling, we definitely think about isotonic C3F8 or SF6.
Normally for primary we use air bubble. Secondary, suppose a patient's got recurrent decimal detachment, or if he's got again a DSEC which is dislocated or something like that, then we can probably think of that. But air works wonderfully well, and complications are very less with air.
And also we don't know the effect of C3F8 on a new graft. So that also has to be taken into account if you're using C3F8.
So the most important thing is to do a total fill of the air and then release it later. And you've done very well. Thank you.